Hello people, in this video we want to look at bronchiectasis. Okay, this is a respiratory system pathology. It is bronchiectasis. It is one word. Okay, it is bronchiectasis, one word it is. Just put a hyphen for you to understand the spelling. Bronchiectasis. Okay. Now what does it affect? The lungs, right? That much you know already. So what are the clinical features? You know, the clinical features are chronic cough with foul smelling sputum. So can you imagine here that sputum will have pus? Okay, that is what you should know this. And that's why it will have foul smell. So sputum which has pus, so it is foul smelling. Chronic cough which is associated with foul smelling sputum. There can be hemoptysis, there can be blood in the sputum, and there can be recurrent pneumonia. Okay, this pneumonia, this is actually foul smelling. Here you should say purulent, like pus containing sputum it should be actually. Hemoptysis means what? There is blood in the sputum, there is pneumonia, recurrent pneumonia will be there. Sinusitis will be an accompaniment. There can be sinusitis with diffuse bronchiectasis. Then in complications of bronchiectasis, there can be clubbing of finger. Do they mean clubbing of the nails? Metastatic abscess often of the brain, amyloidosis, and cor pulmonale. What is cor pulmonale? Basically in cor pulmonale, what happens because of the disorder of respiratory system, the right ventricle gets affected. So that is cor pulmonale. Okay, so cor pulmonale means right ventricle gets affected. In fact, it's very interesting how right ventricle gets affected when problem is with the lung, right? So that is cor pulmonale. Okay. So these are some clinical features that a patient may present with. Okay. Now, what exactly is bronchiectasis? Bronchiectasis, it is a COPD. It's a chronic obstructive pulmonary disease. What is it? It is a chronic obstructive pulmonary disease, COPD. It is can also be called as chronic obstructive airway disease. So it is an example of COPD. Lot of examples of COPD are there. Like chronic bronchitis is there, emphysema is there, asthma is there, bronchial asthma, bronchiectasis is there, small airway disease is there. So all these are COPD. So what is bronchiectasis? Bronchiectasis is nothing but a COPD. Did you understand this much? What is bronchiectasis? Bronchiectasis is a COPD. Just like how asthma, emphysema, chronic bronchitis, etc., you have bronchiectasis. Okay. Small airway disease is also a COPD. So you understood where exactly we are, right? Now, what you should understand is how is it different, this bronchiectasis, how is it different from emphysema, etc. You know, emphysema is caused because of cigarette smoking. However, bronchiectasis is caused because of infection. Infection, mainly infection, okay? Infection will lead to dilatation of the bronchioles. So what you should understand is bronchiectasis is nowhere related to smoking. Emphysema is because of smoking. And bronchiectasis, it is going to affect the bronchus, but emphysema affects the alveoli. Okay. Then moving on. Now bronchiectasis, some more information here. First of all, how it is defined. It is defined as the abnormal, irreversible dilatation of the bronchi and bronchioles greater than 2 mm in diameter. So this should come in the definition. It is greater than 2 mm in diameter. Put your finger here and check. 2 mm means how much? Yeah, 2 mm in diameter if the bronchi and bronchioles are dilated. And this is irreversible dilatation. So sad, it is an irreversible dilatation. Then it is called as bronchiectasis. This is a secondary, it can be secondary to inflammation. That is, if there is an infection, it can lead to dilatation. If there is an obstruction, that obstruction can further lead to infection, can lead to dilatation. So what you have understood here is that we are in chronic obstructive pulmonary disease. So obstruction, definitely obstruction you can understand, right? This infection also can lead to obstruction. Obstruction can lead to infection. Infection can lead to obstruction, dilatation. Finally, what will be there? Dilatation. Okay. So here you can understand what is affected. The distal bronchioles are affected. Okay. Here, what will there be? You saw clinical manifestations in the beginning itself. Persistent cough with expectoration of copious amounts of foul-smelling purulent sputum. So here the sputum is going to be purulent. It is foul-smelling, copious amounts of sputum. That means lot of sputum will be there. And there is persistent cough. Okay. So guys, this man is there. He is coughing a lot and he is producing what? Copious amount of sputum, which is having pus. So it is purulent, foul smelling, lot of bad smell from the sputum, lot of cough, expectoration, etc. It could be what? Bronchiectasis. Okay. Then moving on, post-infectious cases commonly develop in childhood and early adult life. Actually, this is seen in adults. Okay, mainly in adults only it is seen. Young adults, you can say. Etiopathogenesis, there is endobronchial obstruction infection, right? You already know obstruction and infection will cause. This is the actual thing. Finally, this is what happens. But what are the causes for this? That also we will look at. But first of all, endobronchial obstruction and infection. So this infection can happen because of obstruction, or infection itself may lead to obstruction. Okay. Now let us go to the actual causes, guys. What have we seen so far? What are we looking at today? Today we are looking at bronchiectasis. Bronchiectasis we are looking at. We have looked at exactly the clinical features, what these people are going to present with. And then we saw what it is. It is a COPD. There is irreversible abnormal dilatation of the bronchi or bronchioles, mainly because of obstruction, inflammation, infection, inflammation, etc. Right? Then what we saw, etiology, mainly what is the etiology, they come under endobrachial obstruction and infection. That's what we saw. Now let us look at the smaller details. Why there is obstruction, why there is infection, all that we have to look at now. So etiology is coming here, guys. Etiology for what? For bronchiectasis. So there can be hereditary and congenital factors, like congenital bronchiectasis can be there. So cystic fibrosis, what is cystic fibrosis? Cystic fibrosis can lead to bronchiectasis. It's a disease of the pancreas, correct? So defect in the exocrine gland secretions, that is cystic fibrosis, that can lead to obstruction, infection, etc. This is hereditary, that's what they are saying. Hereditary immune deficiency diseases, so people have a lot of infection. Immotile cilia syndrome. This immotile cilia syndrome means, example is Kartagener's. You can remember like this if you want the spelling, Kartagener's syndrome. So basically here the cilia, they cannot beat properly. So when they can't beat properly, they cannot clear the airways, correct? So there can be infection, obstruction, etc., which can lead to bronchiectasis. Okay. Atopic bronchial asthma. Atopic bronchial asthma means what? They have a lot of allergies, right? So they can have bronchiectasis. Now, this Kartagener's syndrome, where the cilia cannot beat properly, right? These people will have a lot of other issues like infertility, because their sperms, they cannot move properly. Then they will have hearing problem also. Because cilia, wherever it works, the entire body there it's not working. Okay. So moving on, these were the hereditary and congenital factors. Now let us move on to obstruction. Obstruction can happen because of foreign bodies. Obviously, this you're very sure of. Obstruction, why it will happen? Now this is the lung. Let's say this is the lung, and here there is something, and here there is an obstruction. Why is there an obstruction here? The obstruction can be because of foreign body, endobrachial tumor, so there can be a tumor, endobronchial tumor, a tumor can be growing here, compressed by something, so there is a lymph node that is compressing on this and hence there is an obstruction, or there can be an inflammation here which has led to scarring, so post-inflammatory scarring. So what there is there now? Obstruction. Now, next thing, as secondary complication means necrotizing pneumonia, tuberculosis. So these are infections that are going to lead to bronchiectasis. Okay. So there is going to be necrotizing pneumonia, like because of staphylococcal infection, or tuberculosis, Mycobacterium tuberculosis. Okay. So these are the causes for the actual obstruction and infection. Moving on. So guys, is this point clear to you actually what exactly this bronchiectasis is? See, this is normal, let us say, bronchiole. It gets dilated, guys. That's all. Irreversible dilation happens of the bronchi or bronchiole. This irreversible dilation is bronchiectasis. That's all. Okay. Guys, we are done with the etiology of bronchiectasis. Remember, it is not caused because of smoking. Okay. Shall we move on now to the next slide here? So we have to look at the gross morphology and the microscopy, right? That is what they give marks for. So what will happen when you look at the lung? It will be involved either diffusely or segmentally. That means everything is involved, or segmentally it can be involved. So as simple as that. Here is the lung. Lung can be involved full, or it can be involved segmentally. So that is what they have written here. Bilateral involvement of both the lower lobes. So if there are two lungs here, both the lungs, bilateral lower lobes can be infected. Okay, this is very frequent. And the left one is infected more. Okay, because it has some vertical air passages. The vertical air passages of left lower lobe are affected more. Okay. What happens to the pleura? Pleura is fibrotic, so it becomes thick, and it is to the chest wall, no, it becomes adherent. Okay. Now, airways are dilated. We already told you the airways are dilated. So, the dilation of these airways can be either cylindrical, fusiform, saccular, or varicose. There are 4 types here: cylindrical, fusiform, saccular, or varicose. Cylindrical is most common. So, look at this diagram here to explain that. So, are you able to see? So, here you have the lung. Here is the normal bronchi, bronchiole, whatever. Here it is cylindrically dilated. See, this one is cylindrical dilation, right? This is just like a parallel, right? Like a pipe. Then you have fusiform. Fusiform means like spindle shape, it is dilated. Then you have saccular dilatation with sacs, right? Saccular dilatation. And then you have varicose dilatation, just like varicose veins, right? Varicose dilatation are there, okay? So these are the 4 types in gross that you will find. So we are looking at the gross morphology of bronchiectasis. Now let us move on to the cut surface and see what happens in the cut surface. In the cut surface, you will see that the lower lobes are usually affected. There is honeycomb appearance. Honeycomb appearance, you can see here, basically what you are seeing here, honeycomb appearance means, what happens, you see here, this is the lung. Can you see here all these dilated bronchi? They kind of give a honeycomb appearance, dilated bronchi, right? Bronchi, bronchioles. And they are dilated towards the periphery, near the pleura. Near the pleura, they are dilated, okay? And the lumina are filled with what? The lumina are filled with mucus or mucopus. So, mucus or mucopus can fill these lumina. So, let us say this is a dilated bronchi. Inside it, you will find mucus or mucopus. And it has a honeycomb appearance. Okay, honeycomb appearance you have also seen in osteoclastoma, right? So, we are just writing this here because sometimes, you'll be like, wait, somewhere I read honeycomb appearance. No. It was an osteoclastoma in the epiphysis, right? If you remember. Anyways, the bronchi are dilated near the pleura. Lumina is filled with mucus or mucopus. What else is written here? One more line is written here. Intervening lung parenchyma is reduced and fibrotic. So, sorry, the lung parenchyma will be fibrotic. There will be less lung parenchyma, more of dilated bronchi, bronchioles. Okay. Then, this is a diagram picked up from the internet actually. Just look at this. So, the left lower lobe is affected more. Here is a healthy airway. And here you have bronchiectasis. Bronchiectasis, the airway is filled with mucus and the airway is dilated. The airway is dilated and the airway is filled with mucus or mucopus, right? Okay. Now, let's move on. Gross is over, guys. Next we have to move on to microscopy. Microscopy will be, let us look at the epithelium. Epithelium may be normal or ulcerated or may show squamous metaplasia. There can be squamous metaplasia because normally what is the epithelium? It's going to be columnar, ciliated, columnar, pseudostratified, right? Pseudostratified, ciliated, columnar epithelium will be there. So, this will become squamous. This can show squamous metaplasia. Remember, in bronchiectasis, you can see squamous metaplasia. Okay. Then the bronchial walls, what happens to the walls now? They show infiltration by acute chronic inflammatory cells. Wherever you will write off this now, one point, everywhere you will write this. Inflammatory cells will be there. There will be destruction of normal muscle and elastic tissue. Normal tissue is destroyed. There is fibrosis, whatnot, same stuff. Right? Normal tissue, destruction of normal tissue. Fibrosis. Lung parenchyma will, what will happen? It will be less, it will be reduced and it will be fibrous. That also you will know. Then, the pleura, we told you the pleura also will get fibrous, it will get adherent to the chest wall. This also you know. Then, that's alright. That completes the microscopy also. So, we are done with the microscopy of bronchiectasis also, guys. So, actually this is what we wanted to cover in the pathology video. Actually, some more points if you want, you can add about the lab diagnosis, treatment, etc. In pathology, as of now, we are not covering this. But lab diagnosis, we saw some X-ray, or what is this? Not an X-ray. Imaging we saw. We saw some imaging. So, you can learn about that. Treatment basically will be, if it is infection, you can give antibiotics and etc. to clear up the infection, right? If it is foreign body, you can remove it if that is the cause of the obstruction. Asthma and all you can treat with anti-allergics, immunosuppressants, salbutamol, all that you can write. Standard pharmacology you can write, okay, for COPD. That's all, guys. We are done with bronchiectasis. Let's take a recap now. Bronchiectasis is a respiratory system pathology. Mainly here the bronchi and the bronchioles are going to be dilated. It is not the going deep down to the alveolar sac. We are talking about the bronchi and the bronchioles. So basically the bronchi and bronchioles are dilated and they are filled with mucus or mucopus. The clinical features of bronchiectasis is that the person will be coughing a lot with a copious amount of sputum, foul smelling, purulent sputum will be there. There can be hemoptysis, that is sputum which has blood, and there could be pneumonia. Pneumonia is what? Inflammation of the air sacs. Sinusitis can be there. How do you define sinusitis? There will be inflammation of the tissue which lines these sinuses. Then as complications, there can be amyloidosis, cor pulmonale, etc. Cor pulmonale is where the right ventricle is affected because of the pulmonary disorder. Okay. Then, clubbing of fingers they have written here. Abscess even in the brain, metastatic abscess in the brain. Bronchiectasis is a chronic obstructive pulmonary disease or a chronic obstructive airway disease. How is it different from the other? Because they affect the bronchi and bronchioles. Emphysema affects the alveoli. Emphysema is caused by smoking. Bronchiectasis is caused because of obstruction infection, finally leading to the dilatation of the bronchi and bronchioles. Okay. Now, bronchiectasis, it is defined as the abnormal and irreversible dilatation of the bronchi and bronchioles greater than 2 mm in diameter, secondary to inflammation or, secondary to inflammation. The inflammation can be because of obstruction, right? Or the inflammation itself, infection can lead to obstruction, okay? So, distal bronchi, bronchioles, especially towards the pleura, are affected. And what else? Etiopathogenesis, you need 2 words here. Obstruction, infection. 2 words you need here. What and all can cause this? There can be congenital bronchiectasis, cystic fibrosis. I think you will end up forgetting this word, cystic fibrosis. Hereditary immune deficiency disorders that can lead to infection, right? Immotile cilia syndrome, don't forget this. Kartagener's syndrome. This can be, you can see infertility also in these people, and hearing problem, not hair problem. Hearing problem, okay. Atopic bronchial asthma, where people have a lot of allergies. Obstruction can be because of foreign body tumor, compression because of enlarged hilar lymph nodes, post-inflammatory scarring as a secondary complication of pneumonia or tuberculosis, okay. It's not because of smoking. Then, gross morphology, you will have to explain that the left lower lobe is affected and the dilated airways can be either cylindrical, fusiform, saccular or varicose type. This you will have to explain and draw also. Then, cut surface, you will see honeycomb appearance. The bronchi are dilated towards the pleura. Lumina can be filled with mucus or mucopus. Intervening lung parenchyma will be reduced and fibrotic. Microscopy, you saw that there can be squamous metaplasia of the bronchial epithelium. The bronchial wall will show inflammatory cells, destruction of normal tissue, fibrosis. Lung parenchyma is reduced, shows fibrosis. The pleura also shows fibrosis and it can be adherent to the chest wall. Treatment, lab diagnosis, treatment can be antibiotics, removal of foreign body, other specific treatments, whatever necessary. Okay. That's all for now, guys. Hope you enjoyed this bronchiectasis video. See you in the next video. Bye-bye.